Hello, and welcome to another edition of Airway on Demand podcast interviews. I am your host, Dr. William Rosenblatt, professor of anesthesiology and surgery at Yale University School of Medicine. Today we are recording from the Yale New Haven Hospital Smilow Cancer Center. And we'll have the pleasure of speaking to Dr. Lynette Mark. Dr. Mark is Associate Professor of Anesthesia and Critical Care Medicine at the Johns Hopkins Hospital. She has a joint appointment in the Department of Otolaryngology, Head and Neck Cancer. At that institution, she's also the Director of the Difficult Airway Response Team and the Medical Director of the Operating Room. Additionally, outside of Johns Hopkins, Dr. Mark is the Chairman of the Advisory Council to the MedicAlert Foundation for the National Airway Registry, and she's also the co-director of the Society for Airway Management Task Force on the MedicAlert National Registry. Hi, Lynette. How are you?
I'm doing terrific. Thanks, Will. How are you?
Very good, thanks. So I wanted to talk to you a little bit about the Difficult Airway Registry. So why don't you just tell us a little bit about the registry?
Okay, so the Difficult Airway Registry is a program created within the nonprofit MedicAlert Foundation that actually colleagues and I started over 25 years ago. And it really came to be because at the time in the world of anesthesia, we didn't clearly identify patients who had difficult airways once we encountered them and had relatively not positive experiences with them. And more importantly, when they left our institution, there wasn't a way to alert other providers. And so we really tried to find some kind of a registry. By chance, I happened to see a book that a colleague of mine had by Dr. Martin Norton, who at that point was a full professor of anesthesia and otolaryngology at the University of Michigan. And he's the first person ever to have created a difficult airway clinic, which was an international clinic, and also had a first concept of a difficult airway registry that he housed at the University of Michigan in the anesthesia department and had his anesthesia residents basically cover it 24/7. He had tried to approach MedicAlert early in his, kind of practice to see whether they would be able to house some kind of a registry, knowing that MedicAlert had actually been the zero index registry for malignant hyperthermia, and it seemed as though they should have been able to accommodate it. But again, the organization really wasn't used to dealing with anesthesiologists, and nobody really understood the concept of what difficult airway was. So with that in mind, I decided to pick up the phone and call MedicAlert, and by chance, I happened to meet a woman over the phone who was the Chicago regional director, and her name was Joyce Drake. And she took an interest in my conversation and luckily was very close to the University of Chicago and decided to make a site visit and teamed up with Andy Ovasapiam. And so Dr. Ovasapiam, who, again, a world's expert in difficult airway, and at that time was running one of the very few difficult airway courses, gave her a tour of the operating room, explained to her basically what this new, teaching approach to difficult airway was all about. And then actually connected with me, and that was my first introduction with, again, Andy Ovasapiam. It was through MedicAlert and Joyce Drake, and that's how the two of us started chatting, and then kind of realized that what we were going to do was create something within the MedicAlert Foundation. And so we did that 25 years ago.
When the registry first kind of was being formed, was it simply at MedicAlert, or were there independent registries besides the one you discussed? I know that the reason I asked the question is I know that at one point Lorraine Foley, back in the 90s, was working on something at her position up in Boston.
Oh, gosh, it was the early 90s, so it was like literally 1991, 1992. At that time in the world of medicine, in the world of anesthesia, there were very, very few registries. And in fact, I think one of the few registries that existed was in cardiac anesthesia, and that was with Dennis Mangano, and I had trained cardiac anesthesia. And that was an attempt for institutions to share data and information, and there were a lot of political issues with that. And again, I was in the cardiac anesthesia world at the time. And I took a look at that, and Andy and I, and actually Henry Rosenberg from the MH Foundation, we had long conversations about what would be the most appropriate ways to encourage anesthesiologists to, quite honestly, share information. And what we realized was that, at least the climate at the time, was that no one institution was going to be giving their medical patients or access to medical information to another institution. But it was really going to be housed in a nonprofit foundation, such that there would be no political arguing of any kind. It was about ensuring that your patients were safely registered and that you had a high identification.
So let's talk about the use of the registry. At this point, who should be using the registry and for what patients?
So the reality is that any patient who would benefit from being in a registry that probably initiates from an in-house registry in your own institution, so that you identify a patient in your own institution and that you can continue to identify that patient through their course of their stay and or if they get readmitted into your own institution. And that's, again, a concept of Martin Norton's in-house registry, our Hopkins in-house registry. It's a bright-colored bracelet. Blue seems to be the color right now that most states are adapting. It started out green, but that was taken over by latex. It's a document on their chart. It's an alert in an electronic record that says difficult airway. It's a letter to the patient that you physically hand them, and you either give them, just you are a difficult airway, or you give them enough of their medical information so that they can hand that letter to the next provider. And or if you really want, you give them your anesthesia documentation. So that's kind of the complete packet. But again, that only helps if they either have that material with them or if they have access to their in-hospital records. Because of the firewalls right now and the inability for one hospital to readily share information, and or the fact that we don't have electronic records everywhere, and a lot of paper charts get stored off-site in a short period of time, if that patient enters into another institution and they either don't know the knowledge of the information because it's fairly technical, or they don't remember being told, and they don't look like they're difficult, another provider might not know it. So again, our recommendation is that any patient that you encountered that you personally experienced to have a difficult airway or needed unusual techniques that wouldn't be readily available to another provider, whether it's an emergency physician or an anesthesiologist or another provider or an EMT, outside that needs to manage their airway, we think those patients would benefit.
What do you think is the minimum difficult airway experience that should generate a letter or generate a call or an application to the registry? Give you an example. Let's say I have a patient who is a difficult mask ventilation, and I wind up placing an oral airway, and now it's passable. This is someone who I don't think anyone would go ahead and recommend that they carry a difficult airway letter or wallet card or be placed into the registry. But there's a spectrum that will then advance to the patient who should be put into the registry. What would you consider the minimum?
So 20 years ago, Andy Ovasapiam and Charlie Beatty, who was my mentor at the time, and I sat down and said, what's really the worst that happens? So what I consider to be kind of the worst scenario at my institution is that in the middle of the night, if a patient comes in who needed to have an emergency, a rapid sequence intubation, which again meant that you pre-oxygenated, you committed to paralysis, you did not initially mask ventilate. So all the safety checks that we would normally do, that if knowing what you now know about that patient, so I was in the operating room during the day and maybe I did 2 or 3 DLs and I switched blades and I wasn't really sure if they were difficult. So I was really hesitant. If that same patient came back in the middle of the night and I was the attending, either by myself or with a junior resident, if I was not willing to do a rapid sequence, I would partially mask or I would take 2 looks or in that case, the answer is they're a difficult airway. And so we went through all the other definitions of 2 and 3 laryngot. We finally just said, if you're not willing to do a rapid sequence, then we recommend that you enroll this patient. In this day and age, it's a little bit harder to ask the question or to answer it. And that's why, because of all of the new techniques that we have, all of the new supraglottic devices, all of the new video direct devices. And so now it really is based on what your experience is and what techniques you needed to do on this patient. Again, if this patient returned full stomach emergency procedure, if you needed extra special things that you didn't need electively, I personally think that patient, and many of us think that patient would benefit from having an alert of some kind. again, whether it's your own in-hospital registry or it's whether you make the recommendation to, and it's only a recommendation for the patient to get registered at more of a national registry, which is the MedicAlert one.
I really like that concept, and I like that concept because I think that we have to evaluate airways in terms of what we're comfortable with. And when my personal interest is how we make decisions in what we're going to do with an airway. And the decision that I make is going to be very different from the decision that you make or somebody else with a lot of experience.
Oh, absolutely.
So I really like that explanation.
I've had the unique opportunity to review about 700 letters that have been submitted to the MedicAlert National Airway Registry. And these letters have been personalized from institutions to see which patients they actually thought they wanted to enroll from their institutions versus patients that I would be enrolling from Hopkins. And the variation is not as wide as people think, and it really, I think, will help us come up with a answer to which patients do we think would benefit. And it really is fascinating. You can see at some institutions, they very quickly go to a video laryngoscope. If that fails, those are the ones who are entered. In others, they never even tried that technique. It might not have been available, so it really was the 3DLs or, inability to mask. But it really has been a fascinating read, and that's something that we're going to be sharing with both Society for Airway Management, and we're going to use that information to come up with a better set of, not guidelines, but recommendations as to which patients we truly think would benefit based on what the collective experience is an awful lot of practitioners out there over the last 20 years.
Mm-hmm. What do you think is my legal obligation in terms of these patients? If I have a patient that I decide I wouldn't do a rapid sequence on in the middle of the night, and I've defined that patient for myself as a difficult airway, what's my legal obligation for giving them a letter or informing them or suggesting that they contact MedicAlert?
So I think to use the word legal obligation is I'm not sure that that's the concept. I think, at least for me, I think the concept is how is it that I've documented it on my in-house documentation? So did I clearly document on my anesthesia record? Did I use the word difficult or not? Did I document it on the patient's electronic record? Did I have a communication with the patient to say either this is what I did or this is what I recommend, and to give them that information? I think if you start with that, I think each provider needs to know what is the constraint within their institution as to what it is that you need to disclose to a patient. And in the old days, I'll be honest, there were many practitioners who did not disclose to their patients that they were difficult. They hand wrote it on a chart. They never said a word to their patient. The patient left, came into our institution, and I spent years, and so did Lorraine, we spent years and years hunting down basically handwritten anesthesia records. And on the record, you would see the word difficult and all of that. But again, the information was never given to the patient for fear of basically saying to a patient, it was me. There was something wrong with me that I found you difficult. I think we've come to the next step. And the answer is, if I am competent in airway management and I have resources around me and I know when to call for help, and I still had an issue with that patient, I think you're obligated to disclose to the patient, period. Now, whether you give a copy of the medical record, at some point a patient needs to take responsibility for knowing what happened to them and how they can access their own medical information. So I'm not sure it's a question of legal or medical liability.
I mean, I think there's an ethical obligation, certainly, to disclose to the patient when there's an issue, especially when there's a high likelihood that patient may, in the next several years, sometime in the next several years, wind up in another institution and
Absolutely.
Can get damaged. I have real questions about the legal obligation and when, I think there should be one, and when a colleague says to me, well, do I really have to write a difficult airway letter? I say yes, but I don't know what the institutional policy would be on a medical legal basis.
Yeah, so I think even at our place, medical legally, and in fact, so the answer is I don't think you have to write a letter, but I think you do have to document on the chart that you've had a conversation with the patient, that the patient has been informed, and or it gets listed at our place as part of the discharge summary. so that the information is clearly there for practitioners. I think it's become incredibly proactive and acceptable now. In fact, that's one of the projects that we're doing is we're doing a little bit of a basically literature search to see how many institutions actually have some kind of a difficult airway identification program just within their institution. Not so much do they go ahead and transition patients to the MedicAlert Airway Registry, but what are they doing at their own institutions? And we're now finding that an awful lot of them, and we're being asked to be consults, have some kind of an identification process for which those patients are being told, do you have a difficult airway, yes or no? You now have been told that you have a difficult airway, and so there's this on layman's terms, on a patient's terms, so that they understand it. So yeah, and there's starting to be a high exposure. I'm not sure what the legal liability is, but it's definitely becoming a medical condition or a medical identification the same way diabetes is, or the same way you've had a heart attack or you have high blood pressure. So yeah, it's no longer a not talked about concept, at least not at our institution.
If I decide to go the route of the MedicAlert registry, is there a no-cost option for the patient?
So this is something that has always been, in my way of thinking, a little bit of an obstacle, and then at some point you move forward. So MedicAlert, because it's a 501c3 nonprofit foundation, what it means is that if you identify a patient that you truly believe would benefit from being registered, and you write a letter to MedicAlert that says, I'm a physician, this patient is not able to pay, they are indigent, they're just not able to pay, MedicAlert will enroll that patient. That's part of their nonprofit charter, and that has always been. And I did that for some select patients. I personally felt that combination of an institution or an insurance carrier should have paid for it in the same way that I prescribe a pill in the hospital, and that it should be part of a medical bill. That part is not easily put through. So institutions can do a number of things, and many have when I've gone through and looked at these letters. You either, so far in the past, you either let the patient enroll themselves, you give them the information, and they pay the fee for MedicAlert, which is a yearly fee, or the institution buys and sponsors, for example, X number of memberships, which is what we've done in the past. We bought 500 memberships from Hopkins and, paid a nonprofit cost to MedicAlert, and then we knew that we could enroll 500 patients for free. So I would say to the patient, I need your informed consent to enroll you, but our institution, our department is actually going to enroll you and pick up the one-time fee of the MedicAlert enrollment fee. And then what I've now seen in these letters is that a number of institutions, which I think is very unique, they're giving kind of vouchers. They're giving a $25 voucher towards the enrollment fee along with their difficult airway letter, which I thought that was very creative. I'd not seen that until I started reading these letters. So your direct answer moving forward is that MedicAlert is trying to work with us. And when I say us, I'm talking about the SAM task force, to try to figure out if they can come up with a new two-part system to the registry. The first part would be that if a physician thinks that the patient should be entered, that the physician themselves can log their credential into the MedicAlert Foundation. They have what's called Premise, which is their electronic record. And that once they verify who I am with my licensure and my institution that I work with, that for free, I get informed consent from the patient, and I now register that patient. That information is there. It's there if you want to get it at Yale. It's there if I want to get it at Hopkins. But the patient themselves can get it, but they don't get the rest of the MedicAlert service, because don't forget, MedicAlert is more than a registry. What they are is a 24-hour response center and an emblem, a permanent emblem, in addition to the website. If the patient then wants the rest of that service, they're traveling, they would want to wear an emblem or something, then MedicAlert would contact them, and then they could pay for the rest of the service. So that's starting to be the vision that MedicAlert is hoping that they're going to be able to get to. At this moment, they're not quite there, but we're getting closer, if that kind of answers your question about free versus not.
Will you be speaking about the registry at the SAM meeting in Seattle?
Pretty sure. I hope so. If not in a formal, it would be at a lunchtime, ask the experts, or it would be in the form of some kind of a poster presentation.
Well, I've been talking to Valerie Armstead and Philippe Ernetta over the last couple of weeks, and it sounds like it's going to be a very busy meeting, and I certainly hope that there's the opportunity to discuss, the registry in some detail in one of those forums or another.
And the fun part is going to be is that the website, again, I just got off the phone with Juliet George, who's their director of research, and apparently the website is up and running for the last 2 days. Again, mostly with the one time, it's not a drop-down menu of any kind, and they've already had a number of requests from institutions to send, 50 or 100 brochures, which I think even Juliet called me. She's like, I can't believe it. The site's been up for 2 days, and we've already gotten, 2 inquiries. So I thought that was pretty neat.
Do you have the URL handy?
I don't think it's as handy as it should be.
That's okay. That's okay. I'll get it. I'll
yeah.
get hold. Well, thank you, Lynette, for taking your time to speak with us today about the registry at MedicAlert for the difficult airway. And I hope to see you at the SAM meeting, and we can discuss this further.
Will, thanks so much again for the opportunity for letting me let you and others know exactly where we've been and how far we've come. And I very much look forward to seeing you at the SAM meeting.
Okay, thank you. Okay, goodbye.
Goodbye.
After our conversation, Dr. Mark informed me that I was mispronouncing the name of the MedicAlert Foundation. In fact, it's MEDICALERT. My apologies. You can access the website of which she spoke at www.medicalerт.org/difficult airway, and that's one word. You can find out more about the SAM meeting at www.samhq.com. That concludes this episode of Airway On Demand podcast interviews. You can find out more information about this or previous episodes by going to www.airwayondemand.com and looking for the AOD PI button or tab. I also hope to see you at the upcoming Society for Airway Management meeting, which will be in Seattle, Washington, September 19th through the 21st. You can follow us on Twitter at Airway On Demand. And this is your host, Dr. William Rosenblatt, signing off and wishing you smooth airways.